All right. Welcome. How's everybody doing?
Thank you, Jeff.
My pleasure. For those of you who know me, it's no secret. For those of you who don't, I have very much an alternate agenda here, of course, which is I have epilepsy, and sharing first aid with those who are going to see me a lot is, it's useful. So yeah, when it comes to, excuse me, the entire presentation that's going on here, unlike CPR and first aid training, there are no quizzes, there are no tests. Your presence gets you the certification. That's pretty much how it works. It's not quite as formal in that regard. Those of you who want the certification, I'll be telling you the same thing at the end. You can email me, and I will get your name on the list with the Epilepsy Foundation. I mean, they can get you a certificate if that's needed for any purpose, and yeah, we'll go from there. So yeah, the presentation itself has a lot of stuff that almost everybody, it's kind of surprising how much information there is about epilepsy in the world that is really not understood. Everybody kind of, you think about epilepsy and you think about somebody having a tonic-clonic seizure, shaking on the ground, and that is a part of what happens, and it is, in general, the most complex and emergency event that occurs, but epilepsy is actually a much bigger disease than that. So we'll go to, the next slide, the Epilepsy Foundation of Eastern PA which is who I'm speaking for. I'm going to see if we have slides. Are you seeing slides, Seneca?
Yes.
Now we're getting the slides up here.
Oh yeah, they're working on Zoom.
So basically, I'm working with the Epilepsy Foundation of Eastern PA, which is the local Epilepsy Foundation location. We don't really need the slide for that. And Epilepsy Foundation is a nationwide organization that does research, education, and accelerations and fundraising for various kinds of therapy and research in that world. There we go. And the next slide is, so some of the services that are provided by the Epilepsy Foundation are Project School Alert, which is a setting where kids in school actually are being taught to understand what seizures are, so that if their classmates are experiencing them, things like that. First responders and law enforcement training, which is extremely important, as we'll talk about. There are a number of different types of seizures that if you don't understand what they are, people somewhat frequently get treated quite badly from law enforcement, who thinks they're on a bunch of drugs or those sorts of things. Transition services for people learning how to do it, support groups of many kinds, advocacy, legal advocacy for more training and awareness, educational conferences, information, Camp Achieve, which is the coolest thing that the EFEPA does, which is a week-long camp for kids ages 8 to 17, a sleepover camp with neurologists on staff 24/7 and nurses who know what they're doing, allowing kids with epilepsy to have an experience that is more like, being a normal person that doesn't have epilepsy, and that's a real big deal. Adult services of all kinds and a young adult retreat. So then the next one is just some basic contact info, which will come up in a few different things, just some phone numbers, email addresses, where you can get additional information if you like. So, why should I know seizure first aid, says the next slide. So anyone, anywhere can have a seizure. So what this is called is seizure first aid training, because epilepsy and seizures, while they overlap dramatically, they are not inherently the same thing. Seizures can occur for a variety of reasons, which we'll go over shortly. Anyone can have one, anywhere. In fact, 1 in 10 people will have a seizure at some point in their life, which the degree to which it's talked about and understood, it's like many people are surprised by this medical fact that actually it's far from uncommon. And then 1 in 26 people will be diagnosed with epilepsy during their lifetime. It is, like I said, far from uncommon. So the next slide, epilepsy is common. Approximately 65 million people worldwide are diagnosed with epilepsy, and undoubtedly, because only certain people, certain parts of our world have access to even a diagnosis for such things, it's actually a much larger number than that. Approximately 3 million people in the US are diagnosed with epilepsy. Currently affects, I think these stats are actually a touch old. It currently affects about 470,000 children and youth, and approximately 1 million older adults in the US are diagnosed with epilepsy as well. So, the next page, just some very general things. So, most seizures are not medical emergencies, especially if they are occurring for a person who already has an epilepsy diagnosis. A person may not be aware that they are having a seizure. We'll talk about a lot of the details of this. Seizures are not contagious. we can't give them to another person that way. A person, that's why I don't have to wear a face mask. A person cannot swallow their tongue during a seizure. This one comes up in many of the slides this is talked about, because it's an old stigma. It is physically impossible for a human being to swallow their own tongue, regardless of the circumstances. But it is a thing that almost everybody goes, oh, I didn't realize that. I thought that was what happened. We don't put things in people's mouths, and we'll talk about that several times too. Epilepsy is a medical disease. That's, as of 2017, it's called an epilepsy disease. Before 2017, it was called a condition. The neurologists will probably change their mind again next time, but that is what it's referred to at this point. And then the last one, a person can die from a seizure, and that's what the first aid really is about, is learning the differences between events that are life-threatening and really need a lot of help, and events that really just need care and comfort, as we typically put it. So, what is a seizure? A seizure is a brief, temporary disturbance of the electrical activity in the brain. It can affect a person's movement, behavior, actions, and conscious. It can be happening in one particular region of the brain. It can be happening in the entirety of the brain. And so that's kind of the overarching understanding of what a seizure actually means. So, some seizure causes, and again, this is not inherently for people with epilepsy. The next page is some seizure causes, which are a high fever, especially infants having a high fever, it can trigger a seizure. Drug use, drug withdrawal, alcohol withdrawal, very common side effects of the, I mean, I'm not saying everybody, but it is frequently the case that withdrawal causes a seizure. Near drowning and lack of oxygen from another cause. Cardiac events sometimes come with that. Metabolic disturbances. Head trauma of some kind, which head trauma can lead to epilepsy as well. Brain tumors, infection, stroke, also they can cause and or lead to reoccurring epileptic events. Complications of diabetes or pregnancy. I have a good friend who has experienced seizures from blood sugar levels from diabetes. And then, of course, some seizure causes. Epilepsy, which is basically what epilepsy means is we don't know what causes them, they just happen to a person who has epilepsy. So, the next slide is, what is epilepsy? Epilepsy is a disease characterized by recurrent, unprovoked seizures. Fairly straightforward. Epilepsy is the same as a seizure disorder. So people often refer to, will say they have a seizure disorder. Most of the underlying roots of this are just the stigma of epilepsy. A lot of people are scared of saying the word epilepsy. So they choose to say the word, I have a seizure disorder. They mean the same thing. Epilepsy also is a very general term. In the bottom right, the thing that we see and can't read off of, it's not important what we can't read. The point is there's a slew of various kinds of genetic disorders, diseases that can lead to it. It is a laundry list of things that can lead to a person having recurrent seizures. So the next page is the causes of epilepsy. As I will say at least a few times, neurology is the last frontier in a sense of modern medicine, because neurology knows a lot more than they did 20, 30 years ago, but they still don't know much. The human brain is quite a mystery. And so approximately 60% of people who are diagnosed with epilepsy, the cause is unknown. That's the crew that I'm in. We don't know, it happens. In about 40% of cases, the seizure cause is known. Brain trauma, brain lesions, tumors, infections in the brain, meningitis, encephalitis, measles can cause epilepsy after those, brain injuries at birth, congenital malformations, and genetic causes. There are a variety of genetic things that come along with epilepsy, in addition to other things often. So the next one, seizure classifications, is kind of the broad stroke of the two major families of seizure types. So generalized seizures are, as the diagram on the right of the screen is showing, a generalized seizure is a seizure that is happening everywhere in the brain. By the nature of generalized seizures, they are not, the person is not aware as they're happening. The person's consciousness is gone. And we're going to talk about more of the details of those that are listed in more specific ways. Focal seizures, also formerly known as partial seizures. You're going to see a bunch of things in these parentheses because a lot of the terminologies for this were changed in 2017. And so if you're a person who has experience from the past, we keep on using some of the terminologies that you've associated, myself included. The old terms, I'm still getting used to calling them what they call them these days. So focal seizures are things that begin in one region of the brain, and the person can be still conscious while they're happening, can have an altered state of conscious, or can become unconscious. And yes, so the next page, the new classifications. Again, there's no quiz on this. It's like you need to be taking a neurology class to really be ready to take the entire quiz. And the stuff on the right is kind of the most important. The old names for things: partial seizures, generalized seizures, simple, complex, and as at the bottom right, disorder. They've decided to call it a disease. These days, focal seizures are seizures that are occurring in one particular area of the brain. Generalized seizures are occurring everywhere in the brain. That's the summary of this page. So, for people that have epilepsy, there are things that are called seizure triggers. The most common of them being kind of in the bottom right, the flashing lights, right? Many people know the common knowledge idea of flashing lights being a trigger of a seizure. What's interesting about this is, while it is somewhat common, really only about 8 to 10% of people with epilepsy are triggered by flashing lights. It's not actually a thing that inevitably comes with it. And just reading some of the others, right? Mr. Late medications, when your system is very dependent on such things, you miss them, you're more likely to have a seizure. Emotional stress, sleep deprivation, hormonal changes, alcohol and recreational drugs, shockingly, I know, and especially uppers, various kinds of cocaine, crack, ecstasy, those kinds of tend to be triggers, whereas in general the downers don't tend to have as much of effect. In fact, many of us, many of the epilepsy medications are actually strong downers. Drug interactions of various kinds can cause seizures, missed meals, nutritional deficiencies, and then the specific stimuli listed, the flashing lights or patterns, very common, hyperventilation, which is one of my triggers, other kinds of stimuli, sudden loud noises, and in a small group of people, music can trigger seizures. I've always felt like, as a professional musician, I would really not like that to be my trigger, but we'll keep our fingers crossed. So we start to get into the first aid parts of it. So the routine first aid, as it's put, is care and comfort. A lot of situations where a person is having a seizure, they basically just need reassurance and someone making sure that they're not doing something that is life-threatening. Like it says, most seizures are not medical emergencies. So all seizures should be timed and documented. So that's kind of the first lesson of, as soon as you're with a person and they're having a seizure, start timing it, because that becomes a major factor. Documented it, that is, being able to tell the person afterward what you saw. Really helps them and their neurologist understand more deeply what type of seizures they're happening and how to treat them. Basic first aid for them has many common elements, but varies depending on whether there is no change in consciousness, altered awareness or unaltered state of consciousness, or a total lack of consciousness. And we'll keep on breaking this down. So the first one on here is the generalized onset motor tonic-clonic seizures, which are the ones that are most well known, and they are the ones that are in general most life-threatening. So when a person has a tonic-clonic seizure, they are completely unconscious while it's happening. At the beginning of it, you will hear a sudden hoarse cry, as it's referred to, which is literally all the muscles in the body tense up, and all of the air of the lungs is expelled, which creates a hoarse cry, as it's referred to. The person has lost consciousness. If it happens completely out of the blue, the person will fall. Their body becomes rigid at first, and then convulsions, stiffening of the arms and legs, followed by rhythmic jerking. Shallow breathing and drooling may occur. Possible loss of bowel and bladder control may occur. Occasionally you will see their skin, nails, and lips turning blue, because while everything is going on, breathing slows down, stops, or is highly limited. Generally, these type of seizures last 1 to 3 minutes. Most of them fit that description. And then they are usually followed as the person returns to consciousness. As I like to refer to it as pretty much rebooting from ground zero. And so you will the person experiences confusion, sometimes a headache, tiredness from having all your muscles exerting themselves completely, soreness, speech difficulty. It takes a little while to be able to get back to the point that you can articulate clearly as the brain reboots. So the first aid for tonic-clonic seizures on the next page is, and you'll see this at kind of the top of the list for all of them, is stay calm. Because the events, when you're not familiar with them, my wife has seen it a million times and she's perfectly chill. But when it's something that you have not seen before, it's scary. And so step one is don't freak out. At least try not to. And so protecting the person from potentially harmful objects, clearing space around them, anything that they might be able to bang into. Like we said before, observe and time the event. Ensure that their airway is not obstructed. So there's a couple things that go with this. If a person has a tight neck piece on, a tie or something like that, loosening the tie, unbuttoning various things, making sure that necklaces or things like that are out of the way. Most of us who live with epilepsy and have such seizures don't wear tight necklaces, but you never know. So turn the person on one side to prevent their choking. This is one of the most important things about first aid for a person having a tonic-clonic seizure. If they're on their back, the spit and saliva that's coming out can choke them. So turning them on their side allows the mouth to empty of such things. Cushion and protect their head, also extremely important, because the person will be jerking around a lot. It's very easy to bang your head into various things, whether it's a pillow, whether it's whatever you've got on hand, their jacket, a shoe is better than the concrete, kind of anything will work. Use a blanket or a towel if the person loses bladder or bowel control. This is something that doesn't occur super frequently, but it does occur sometimes. remain with the person until they're fully conscious. And then the next one on the list, follow the seizure action plan. That's referring specifically to people who are known. So if it's a family member, you have a seizure action plan in place. In school systems, if you are a parent of a kid with epilepsy, you give the teachers and the school nurse a seizure action plan, which can give more specifics of that person's type of epilepsy and what to do about it. What's normal, what's not normal. And so then, extremely important as well at the bottom is if a seizure lasts longer than 5 minutes, call 911 if you don't know what's going on at all. Always make the mistake of calling 911, and or follow the emergency protocol. That is, if you know the person and if there is already a plan in place. And the reason for that basically is once it goes over 5 minutes, it very much becomes a life-threatening event. Not breathing for longer than that is problematic, and it can also become what's called status epilepticus, which is when a seizure doesn't stop, it just keeps going. And so again, don't put anything in their mouth. Never put anything in their mouth, no pencils, no nothing in the mouth. Doesn't help, it'll help them just chew their tongue apart. And do not restrain the person. It's actually so this one's a little bit counterintuitive in that, you want to hold them down or something, but all that happens because the person is using their musculature full bore, absolute, as strong as they possibly can, what you do by that is you actually give them more potential to dislocate joints with their own strength. Actually, you just want to let them go through it, have the jerking motions without being constrained. And and so the next slide gives us kind of the typical stages of a seizure, and this one is, the stages without the video. The video is thwarting us. Can we get to what's behind that? I mean, this is largely stuff that we've already gone over. We don't need the video yet. Everything's going to go perfectly smoothly, though. If it doesn't show up, it's not actually super important. We've sort of already talked about it. But the 4 stages of a tonic-clonic seizure in a classification like my own is first what's called an aura stage, which is where the person begins to feel off, begins to feel odd. Not all people have that. It's also called there it is. Thank you. So the aura stage is the person might be feeling things that resemble hallucinations, confusion, dizziness, numbness, distorted emotions. They're still conscious during this stage. But auras, also known as simple partial seizures, also known as focal aware seizures, they can be all there is to it, and it can end there. But often, an aura will then become a tonic-clonic seizure, where the person goes down. Those of us like myself who have auras before their tonic-clonic seizures, as soon as I feel the aura, I get down so I don't fall, and I'm aware enough to be able to do that. I can tell somebody that I need help. And then when the tonic stage begins, that's what happens first, which is complete stiffening of the entire body, incontinence sometimes, the epileptic hoarse cry. And then as the muscles begin to tire out, you have the clonic stage where the motions begin to become jerky because the muscle structures are no longer able to keep on being still, blinking of the eyes. And then the post-ictal stage, which exists in every seizure type, but this is basically as they're waking up, weak limbs, exhaustion, tiredness, trouble concentrating, and those sorts of things. So the next page is the post-ictal time. And post-ictal basically just means after the seizure. And so after a seizure, he keeps coming back. He really wants to talk. Yeah, there we go. Thank you. So the post-ictal time is after a generalized seizure subsides, the systems take time to return to baseline, to return to normal, that is. The person might be drowsy, confused, upset, sore, nauseous, and or have a headache. And so if we're doing seizure first aid, we give the person time to reorient, which can be anything from 5 minutes to 30 minutes for the person's brain to get back to completely baseline. So one of the easiest ways or best ways to know about this is asking the person, what's your name? Where are you? Some of those just basic understandings of, that can gauge where the person's awareness is at that point. And the person will often need rest after a generalized seizure. As I often say, it kind of feels like you got run over by a bus. So the next page, so any questions? Does anybody have any questions about this particular seizure type? We're talking about tonic-clonic seizures, shaken on the ground, the most well-known. Any questions in person or virtual, if there are virtual questions? Yes?
Is that what used to be called a grand mal?
Yes, so the question was, is that what used to be called a grand mal seizure? And that is correct. Yes, that is and there are plenty of folks who still refer to it as that. I'm pretty sure that language changed about 25 years ago, but it is still known as the grand mal seizure. My wife still insists on calling it a grand mal seizure, and she likes the way it rolls off the tongue better, I think. Yes.
I'm guessing with each police department it would be different. Do you know if there's it isn't like it has to be that they get this training for police departments?
Correct. It is. There are not any mandates about this training at all at this point, and we are working very hard, the Epilepsy Foundation, on creating dynamics where it's. We do still. What's that? Yes, so New Jersey just recently passed Paul's Law, which is the kid Paul actually I was the counselor in his cabin for that camp last year, and they basically have put laws in place that require some very, very basic first aid training for all teachers in public schools and for all law enforcement, so to at least be able to identify the very emergency dynamics.
Thank you.
Absolutely. And we're good online, you said? Cool. All right, so the next group of things are what are called generalized onset non-motor seizures. So in a sense, it's the opposite of a grand mal seizure, in that the person's muscles don't go full bore in every direction, but actually the person's musculature goes completely limp. And so a pause in activity or a blank stare can be what happens in an absence seizure. I'm actually getting ahead of myself. In the absence seizure, the person is still physically, their body is still in control, but they are 100% gone consciously, typically for only 1 to 10 seconds. This is one of the most commonly non-diagnosed seizures for long periods of time. It's often just referred, oh, the kid must be daydreaming, that's just basic inattentiveness, or they have ADD or ADHD, and they're just, whereas in fact these are seizure types that for some people happen hundreds of times a day, and even though it's not so life-threatening as a tonic-clonic seizure, they are an enormous dilemma for learning and being present. And so this one is a video that's all of about 4 seconds long of this young lady having. And it almost looks like nothing. Essentially, her eye contact just stops for a couple seconds, and then she looks back up. And that's all that an absence seizure looks like. It's extremely easy to not perceive that what's going on is an epileptic event. What was your question?
It just looked like you just glanced over for a second.
Pretty much. Yep. It's a very, very brief event, but it's a major dilemma for things like driving, things like learning. When you're driving a car, a couple seconds of losing your attention can be a major problem. And so there are many people with epilepsy that's uncontrolled don't get to have a driver's license. The next cluster, the next group of seizures in the generalized world, again, they're happening all throughout the brain, is a generalized onset motor seizure. Myoclonic seizures, which there are sudden brief shock and shock-like muscle jerks, similar to, we can probably all relate to, the very common muscle jerks that you have as you're falling asleep. That basically is a myoclonic seizure. It's not an epileptic event when it happens when you're falling asleep. Those events, when they're happening throughout your day at random occasions, that's called myoclonic epilepsy. So it can involve parts of the body or the whole body. Consciousness is not completely impaired, but it does involve the whole body. That's why it's referred to as generalized. And it may often cause the person to spill things, right? The dilemma for people who have this type of epilepsy, a hot cup of coffee can create a problem. You know, you can't be working over a stove in any kind of traditional way, because all it takes is one jerk for things to go very wrong. And like it says at the bottom, like all seizure types, these may occur once. They can also occur in clusters, where a bunch of them happen in the same day, in the same few days. And then atonic seizures on the next page are generalized or focal motor seizures, as they're referred to. And this is why I had jumped ahead to where muscles suddenly become limp. The person may drop things, eyelids droop, their head may nod forward, and if generalized, if they're occurring everywhere, the person will collapse, fall to the ground, and the person may or may not remain conscious during this event. There's a terrific book that I've read by a New York Times best-selling author who has epilepsy. It's called A Mind Unraveled, and he has atonic seizures. He has a variety of types of seizures, but he has these where he remains conscious, and so he can describe experiences of falling downstairs where he's completely awake but has no control of his body as it's happening. Typically these last less than 15 seconds. They're fairly brief events. People with these often need helmets or other protective gear because of things like falling downstairs. So the first aid for this group of types of seizures, not terribly different than the stuff before. Timing the seizure is always crucial. Again, if it goes over 5 minutes, that's a problem. Observe and record what's going on for the person. Stay with the person until they return to baseline. Check for any injuries. And then especially for absent seizures, repeating information that might have been missed is extremely helpful for the person. And I already restated, I'll say it again, right? If it lasts longer than 5 minutes and you don't know the person at all, call 911. So this pie chart on the next page just gives, the pie chart itself is using the old terminology of partial seizures and generalized seizures. But it gives you kind of a good perspective on how much the tonic-clonic seizures are 23% of events, and that's the type of seizure that is most known to folks who haven't taken this class before. But actually, complex partial seizures, simple partial seizures, and I love the 7% of unknown partial seizures. The great demonstration of how much neurology still really just doesn't understand about some of this stuff. And then the generalized side that's orange, talking about the various types of seizures that are occurring throughout the brain. Again, there's no quiz at the end. So it's a lot. So the next page, again, has basically a brain layout of all the different regions of the brain and how pretty much the way these focal seizures occur. They can start anywhere. And it's why when you meet people with epilepsy, each person's experience is quite unique, because if your seizures are starting in one particular area, your experience of what feels weird and the various kinds of hallucinations or mystical experiences are very much created by that. Long before my diagnosis, I felt very much like I had many hundreds of focal seizures before my tonic-clonics, and I very much experienced things that felt quite mystical. Like I used to describe it to people like the meaning of life was on the tip of my tongue, but I couldn't get it out. It's these days mine feel like I'm in a cathedral, but I hear my own voice from like, 100 yards away on the other side of the cathedral. And it's just an altered state because of the regions in your brain that are happening. And that, having talked to many people, it is just so different from one person to the next, what they perceive. So on to the next page, the focal onset aware seizures that are also called auras, like we talked about before, and they're formally known as simple partial seizures. As I often say to my neurologist, you call them simple partials, but they don't seem simple to me. Consciousness is not apparent, so the person is still awake and aware of what's going on. There are sometimes involuntary movements, twitching of the arms, face, or legs, various sensory symptoms, tingling, weakness, sounds, smells, tastes, visual distortions. If any of you have ever watched 6 Feet Under, the incredible show that 6 Feet Under is, right, where the lead character has brain issues and ends up, dying from his brain aneurysm, he also has epilepsy that is portrayed. They don't ever say epilepsy in the entire thing, but the first event in season 1, he pulls up to the drive-through and he goes, oh, I feel this feeling of deja vu. And then he says, he smells like rotten eggs. And they are portraying a partial seizure occurring for him because of his brain thing. As it says there, the psychic symptoms that come with it: deja vu, hallucinations, fear, joy, anxiety, euphoria. Mine trigger euphoria, which was a lot of why I didn't get diagnosed for a long time. Was they felt great. It didn't seem like anything was that much of a problem. It's the meaning of life, almost. Usually, the duration of these is less than a minute. They may be confused with acting out, a mystical experience, a mental illness, psychosomatic illnesses. And so on the next page, the first aid for focal onset aware seizures is, once again, stay calm, time the event, time the seizure, reassure the person that he or she is safe. So in these events, the person is aware and still able to perceive you in some way or another. So reassuring them that they're safe, explaining to others what's going on, protecting the person's privacy if there's a situation with that, and then clearing an area around the person in case the seizure generalizes. So when a seizure starts in one place, sometimes it spreads out and becomes a tonic-clonic seizure. So whenever you have any of these kinds of events with a person, clear a space for if they were to become a tonic-clonic seizure. And once again, if the seizure lasts longer than 5 minutes, call 911. And that includes, we're not just talking about a person having a tonic-clonic on the ground. If the person is having these hallucinatory, simple partial seizures, if that goes over 5 minutes, that needs to be considered by a doctor because that is status epilepticus, partial status epilepticus, which I have experienced. Yes, we have an online question.
Okay, is this working?
Yeah.
All right, because longer than 5 minutes can be life-threatening, wouldn't it be wise to call 911 immediately, then cancel the call if it lasts only 4 minutes, especially if you're in a rural area?
And that's a very fair question. And the answer is a bit of a blurry line. I do agree so really the official stance of the Epilepsy Foundation when it comes to that and neurology is that if the person is well diagnosed and the events are known and the events are occurring in normal patterns, you don't need to call 911. If it's a person that you don't know, certainly there's no problem with that. And again, when in doubt, call 911. Yes.
Like yours changed, if that happens, if the pattern.
Yes, whenever a person is having a new set of patterns and things are not going according to the way that they typically do with their diagnosis, that's also a time to call 911. Cool. Anybody else here have any questions? Yeah.
Who can technically diagnose these? Is it only the neurologist? Because I'm thinking about clients I work with, and we always want to rule out medical stuff, so I send them to the general practitioner. I know how hard it is to get in to see a neurologist. So who can typically, and that's a problem.
Yeah, so the question is who can diagnose epilepsy, and really it is just neurologists that will do the actual diagnosis. In fact, even among neurologists, it's pretty much epileptologists that are specialists in that particular thing. If you're going to a neurologist who specializes in Parkinson's, they're going to send you to an epileptologist. And I wholeheartedly agree that they are hard to get an appointment with, which to some extent, that's where the emergency dynamics are actually quite useful. If the person is having a seizure and you just call 911, that sometimes gets you to see an epileptologist sooner.
And on the website for this association, is there a listing of like places where you can find per state?
Yes, there are various recommendations for this. We live in such a fortunate area in Philadelphia. There are 3 different hospitals, Temple, the UPenn hospitals, including CHOP and Jefferson, that are, 2 of them are 4-star, 3 of them are 4-star. One of them is technically a 3-star hospital, just because there are a few procedures that they don't do, but that's Temple, but they're off the charts good in terms of their epilepsy departments. And so many people come from places far away to work with the doctors in Philly, New York, Chicago. Cleveland has a really good place as well. Yeah. Another question?
Are neurodivergent persons more likely to have seizures, especially unanticipated seizures?
I can't claim to know the specific answer to that question. I mean, I do think it's probably overall a yes, because neurodivergent is its own catch-all category.
And just from personal experience, a lot of people with epilepsy do also have a lot of neurodivergency. Not
Yes.
inherently, but
Yeah, there is so much overlap between a variety of conditions and epilepsy. For what's that? Right. Tourette syndrome is a cousin of epilepsy, basically. It is really a version of myoclonic seizures, the jerky motions, occurring in their own ways. They are very close relatives. I don't know if these days they refer to Tourette's as explicitly epilepsy, but it is very related. Yeah.
They tend to relate Tourette's a lot more to OCD.
Yes.
Also, I did have a question. So for these focal aware seizures, you're saying call 911 if it's over 5 minutes, right?
Yes.
Well, I didn't see up there that one of the conditions was shallow breathing, so I'm just wondering why call 911?
So it's call 911 because of what's going on with the brain. The need for emergency services, I myself have experienced focal seizures that lasted like an hour or so, and the damage that's being done to the brain is extreme because a particular region of the brain is just going and going, and it's referred to often as like a feedback loop. Basically, your brain gets stuck in a feedback loop, and the particular region of the brain just keeps on sending the signals round and round and round, and that can very quickly do very bad things to people, to whatever region it's happening in. It can do very severe brain damage quite quickly.
Okay.
Yep. Sure. All right. So the next group is very, very important. Focal impaired awareness seizures, formerly known as complex partial seizures. In that the pie graph that we saw, this is a big chunk, 37%, if I'm not if I remember correctly, of seizures are these. And in a couple minutes, we have a couple videos of these. They were the videos trying to get ahead of themselves. So what happens in this is an altered state of awareness / just a complete lack of awareness. Sometimes people remember some little muddled details, but most of the time, most of the people that I know with complex partials they have no memory of the event after it occurs. A blank stare, a dazed look, automatisms, picking at clothes, lip smacking, chewing, nonsensical speech, clumsy or disoriented movements. So these are happening in particular regions, but they're regions that are affecting a lot of things. Aimless walking, picking things up, loss of bladder or bowel control. These often last 1 to 3 minutes. And they're followed by, like many, tiredness, headache, nausea. And these are the ones that are most frequently confused with drunkenness or drug abuse. And in a sense, rightfully so, because it's hard to tell the difference between a person who's taken too many whatevers or a person who's having a complex partial seizure. And then aggressive behavior can occur if the people that are having the complex seizure, if you become aggressive toward them, they respond much more just automatically, the way our not our conscious mind, but the way our reflexes tell us to respond. And so the next page, theoretically, has a couple of videos, because these are useful to see. So if we can start with the young man on the left, yeah.
What are those weebles doing? They're out of control. I'll tackle it.
And that's all there is to it in that particular case. Eye blinking and the unconscious experience. Now, the next thing is going to go a couple minutes long with a couple of demonstrations and discussions from folks talking about the nature of a complex partial or focal impaired awareness seizure. Go ahead.
Another common form of seizure that is not nearly as obvious is the complex partial seizure. When a small part of the brain is affected, the person will still be able to perform gross motor functions, sitting upright, her actions, stare, mumble, blink excessively, smack their lips, however, it will be totally.
The visuals are the most important part, really. Audio's being a little funky. But yeah, they are events where the person is still able to move, still able to appear conscious.
So too, not only ethnic, but also physical. Since the passage of
The audio's being funky. Let's scrap this one. That's enough. So the important part you did get to see of that first person in he almost looks like he's just conscious and drank too much last night, but what's going on is a complete lack of awareness. And so the first aid for those things, again, timing the seizure. And so because the person is in impaired consciousness, speaking slowly and calmly, what you say literally is irrelevant. They are not perceiving language. Speaking softly and calmly to keep them relaxed. Guiding the person away from potentially harmful objects such as tables, chairs, doors, swimming pools. And in general, when we do that, we want to be guiding them from behind or beside them. If you get in front of them, you trigger a very automatic response that will sometimes come with aggression. So just gently pushing and guiding away from dangerous things is the fundamentals of it. And as it says, allowing for wandering in a contained area. You might have to be the one doing the containing. And then again, just like all the others, if it lasts longer than 5 minutes or another seizure begins before the full awareness is regained, call 911. For this type, write a couple of do nots: do not restrain or grab the person. This is the most frequent occurrence that happens with law enforcement situations, where the person's being told to put your hands behind your back or that sort of thing, and the person doesn't do it, and then more aggressive things occur from the police officer, and the person responds with natural aggression, and it's one of the ones that we're working as hard as possible to help law enforcement understand better. Don't shout or expect any verbal instructions to be obeyed. Any questions about that stuff? Okay. So the next page, I'm not going to read the entire thing. It's really just a very subcategory of this all, which is what are called these days called functional seizures. Another page along, perhaps. Yeah. So functional seizures are actually, they're formerly known as psychogenic non-epileptic seizures. So these actually aren't epilepsy. These are events that occur to people, often people who have various forms of PTSD, anxiety, where the person, a lot of what goes on is a lot like a partial seizure, but they are not actually you know, if you put an EEG and measure the brain waves of what's going on in the person, you're not going to see any abnormal brain waves going on, which you will see for a person. That's just a useful thing to understand, just that there are different types of similar events that are easily mistaken. It's why working with an epilepsy specialist doctor is almost essential to be able to find a true diagnosis of what's going on. So the next page is, when is a seizure an emergency? We've discussed a decent amount of this. So the one at the top is if it's a first-time seizure. A first-time seizure of any kind, the person doesn't have a diagnosis, it's not known, call 911 immediately. And so if this is occurring for a person that you don't know, we'll talk a little more detail about it, but calling 911 is the way to go if there is any doubt that the person has epilepsy or not. Again, a seizure lasting more than 5 minutes, call 911. Status epilepticus, which is pretty much what a seizure lasting more than 5 minutes is technically called. Repeated seizures without regaining consciousness. So that if the person shakes around, stops, and then starts having a tonic-clonic seizure again, but has not come back to being awake at all, that's what's called a seizure cluster, and we call 911 as soon as the second one starts. If the person is already diagnosed and having more seizures than usual, or a change in their type of seizures, it's an emergency. If the person has diabetes or is pregnant, for a couple different reasons. If the person has diabetes, the blood sugar issues and whatnot need help. If the person is pregnant, obviously there are issues for the child. If the seizure occurs in water, any seizure that occurs in water, really the tonic-clonics are the loss of consciousness seizures that occur in water. We have to call 911 because you can feel fine for a couple hours after you've breathed in some water, but things can actually go extremely badly after that. And so we just always call 911 if it's happening in water. Question?
The audio is working if you want to show the video. Yes, there's a question.
All right. Will people with epilepsy have their seizure action plan on their person? Is there a Medicaid alert in some way to identify them?
Very good question. The answer to that question is coming up in a couple slides, actually, so we'll go with that. So yeah, if the person is injured, which frequently happens with tonic-clonics, banging the head is very simple, dislocation of various joints occurs, and then finally the last one, if the person requests an emergency evaluation, which is typically going to happen with adults who post-seizure, if they say, I need help, call 911. And as it says at the bottom, since this presentation is both for the general public and for caregivers, people who have relatives, family who have epilepsy, you should follow the seizure emergency protocol as defined and worked with from a healthcare provider. We get to that a little bit more. So the next page is a relatively short description of SUDEP, sudden unexpected death from epilepsy, which really, it's largely a misunderstood thing that occurs. It's basically when a person has a seizure and they die, and an autopsy cannot actually say why. It's not inherently breathing, it's not a heart attack, it's something that happens, and 1 in 1,000 people with epilepsy will die from SUDEP each year. The next page, the summary of seizure first aid with next page after that, we're skipping that one. Yeah, so tips for encountering a stranger having a seizure. Again, at this point, this is largely review. You're observing, you're paying attention. If you have noticed their normal behavior, if they're a coworker or something like that, you know what normal is. If they begin to demonstrate various possible seizure symptoms, as we've discussed, you proceed accordingly. So this is answering some of the questions just asked. So asking others in the area if they know the person or if they know any history of epilepsy, if the person has epilepsy medication in their possession, which many of us do. Everywhere I go, I've got my emergency nasal spray and my magnet, which we'll be discussing shortly. And as it says, magnets or wrist or can be on the wrist or the pocket for VNS and RNS, which it comes up in just a minute. Medical alerts, ID bracelets, necklaces, cars, or in my situation, my tattoo, because I got bored of the bracelets. The medical ID on a smartphone. So this is actually really important, not just for people with epilepsy. Many people don't understand that you can set up a medical ID on your smartphone for what medications you're on, everything, and it is accessible on your smartphone just like a person who doesn't use your smartphone can make an emergency call. When you swipe up on a smartphone, and they don't recognize your face, what comes up is that emergency call, and in the bottom left, if the person has equipped it, it will say medical ID. You click medical ID, and it has their diagnosis, their doctors, their emergency contacts, their medications that they're on. And again, this is useful stuff whether you have epilepsy or not. And if you call 911 from that phone, all of that information is instantly given to the emergency people you're contacting. Yeah, right? It's like all of us should do this. It's a super useful thing with modern technology for getting a lot of important information shared very quickly. It should be common knowledge, right? So yeah, I highly recommend that for people with epilepsy caregivers and for people with any condition with any medications that you're on. And so the final stuff, you act what to do, perform the seizure first aid in the ways that we've discussed, call 911 if needed, stay with the person until they return to baseline, and have a safe way to get home. So that is pretty much the summary of all of the specific first aid stuff. And this last section is specifically targeted toward caregivers or people with epilepsy on what do you do? What are the treatment options for epilepsy? Anti-epileptic drugs are first on the list. There is a slew of them. Yeah? Is there a genetic component to epilepsy? Yes, there are many forms of epilepsy that are directly related to genetics. Yep, they can be epilepsy can be passed in the family, and then there are also lots of various genetic mutations that lead to epilepsy, and sometimes along with many other things. So surgical options exist in increasing numbers of them. The ketogenic diet, which has been used for over 100 years for people with epilepsy, and it does work. What's funny is it works best for people that are kids, because they have parents to keep them to it. Those of us that are adults, like, the ketogenic diet is hard to keep. When they're like, that cupcake looks good. So they recommend it more for children pretty much for that reason. And so then the two things down below, the vagus nerve stimulation implant and the responsive neurostimulation implant are two of the most cutting edge treatments. The VNS has been out for almost 20 years, the RNS for about 10. The next page has just some common medications. Again, we don't have to look at it. The only important part of it is that about 70–75% of people with epilepsy have seizures that can be well controlled with medications. The vast majority of people with epilepsy, the medications will do the trick. And that's where working with a neurologist, they can target your specific type and use medications that will work well for that. On the next page is medical marijuana. Many of you may have followed that the introduction of medical marijuana into the mainstream. The poster child for it was Charlotte's Web, which is a CBD-focused marijuana plan that is used for people with epilepsy. It was in fact what's that? Yes, children specifically, and it has and does work wonders for some people. The particular person that was used as the poster child for legalization was having 300 seizures a day, and when they were using Charlotte's Web, it went down to 1 a week, which is a life-changing difference. And so the overall summary of the medical marijuana section is, because it is still very variable in terms of how it's done and what it's used for, consult with your neurologist about what to do, the potential for whether or not that works for you or your kid or relative. On the next page, the common side effects, which are aplenty, because epilepsy drugs are no joke. They're heavy drugs, and they, in general, are going in the direction of sedatives because, you know, mellowing out your brain activity makes it less likely for you to have a seizure. So on the left side of what we're looking at are toxic things that can happen: blurry vision, dizziness, lightheadedness, sedation, slowed thinking, feeling drunk, coordination problems, and if they get too extreme, whether the drug's working or not, the person isn't really living. And that's, for those of us on the journey, it's always a balance between those things. And then drug-related side effects, cognitive problems, fatigue, weight gain or loss, cosmetic issues, hyperactivity, slowed movements, personality changes. Pretty much, it's like what this should say is pretty much everything, you know? Pretty much anything can happen. That's been my experience. And then on the next page are what are referred to as rescue medications, all in the benzodiazepine family, and they're all heavy downers, which are able to be administered in a variety of ways. The one that I have with me is a nasal spray, which basically, if I'm having, I have simple partials, the focal aware seizures, and if I have one that goes longer than about 2 or 3 minutes, I use this, and it can very immediately relax my system and make those stop. And yeah, so again, consult doctors about such things. And then the next page is surgery options for people with epilepsy, which can be considered after at least 2 anti-epileptic drug treatments are insufficient. Surgical evaluation includes inpatient video and EEG monitoring. So fun, so fun. They take you off all your drugs and have you, take do all kinds, stay up all night and drink lots of Monster energy drinks, whatever you can do to. They literally will let you bring a 6-pack in and then get yourself hung over so we can try and cause a seizure that way. Yeah, I mean, it's a wild journey. Yeah. And so then other possible tests: MRI, SPECT scans, PET scan, the SEEG, which is like an EEG, only the sensors are not on the outside of your brain. They wire them into your brain in the particular regions where they start. And deciding factors on these things are the ability for the doctors to identify focus locations of the seizures, if the area of the brain involved can be safely removed without resulting in a significant deficit. And patients and caregivers feel that the treatments have been unsuccessful. The procedures include the focal resection, which is a very small spot if they've identified a particular spot, the temporal lobectomy, where they take out a chunk of the temporal lobe in particular. I have had that surgery twice. They took a golf ball and a half the first time. They needed another half a golf ball. They decided on the second. The lesionectomy, the hemispherectomy, which is the most extreme of them all, where virtually an entire hemisphere, one side of the brain, is taken out. There's a remarkable case of that occurred about 10 years ago in Bucks County. Oh, that happened, right, she was a child who was having 300 seizures a day. Grand Mal's, yeah, tonic-clonics.
It's possible that Ben Carson was the one who did her.
Yeah, I think that's the case. We'll forgive her for that. But yeah, and she now is a psychologist and a speech pathologist, and hasn't had seizures in 20 years. Modern neurology is incredible. Patients go home after a short stay typically, and then will likely need weeks or months to return to school or work. Next page is the ketogenic diet. We don't need to go into the details of it. You get the idea. If you want more information about that is accessible with the Epilepsy Foundation. The next page is the vagus nerve stimulation. As you see, basically they put an electronic device in your chest and run the cable of it up to the base of your brain. And it's essentially a pacemaker that's giving you signals constantly. And on the next page, we see the VNS magnet, which many people with a VNS wear on their wrist or on a purse or on a necklace or something like that. And it's a magnet that can be waved across it, giving an extra boost of electricity through the VNS, which can interrupt the electrical pulses of the seizure itself. And then the next page is the responsive neurostimulation RNS implant, which I have. And that is, as you see it at the top, it is implanted on the surface of the brain, and then wires are run into the brain to the regions where they've identified where the seizures start. And it's doing two things. It is sending regular electrical pulses into the particular areas where your seizures start, basically trying to create neural pathways that become connected that aren't your normal pathway to a seizure. And then also, this particular one is also doing a constant EEG on that region of the brain. And literally every morning, I hold a wand, it's like a Star Trek, straight up Star Trek. I hold a wand over my device, and it downloads to a computer, and I send it off to the company who has AI constantly evaluating what's going on in my brain, and then it uploads new responses to it to learn. And people who have that implant over the course of the years that follow, seizure frequencies overall go down. I mean, it is wild stuff. Even I just feel like the story of it is always so amusing. Yeah, so that's what the magnet that I keep around with me, basically, if I hold that over the spot where it is, it gives me a larger shock, which helps me to get out of a seizure, and it also marks for the AI to pay attention to this specific event that's happening. Used for patients with seizures originating from one or two regions of the brain. The magnet can be used for extra stimulation every 10 seconds during a seizure, and the RNS must be shut off for an MRI. Yes, I can't go through the normal electric, the metal detectors. I have to go through the special ones or get it to just do the wand. And then the last one on here is the deep brain stimulation, which is the same as the RNS. It's just that the places that it's implanted much deeper and often on both sides of the brain for people who have many more ways and places that the seizures begin. So some of the last couple things here are the seizure observation record to be completed by an observer. A lot of this stuff is for people who are caregivers, or if you're observing a person having a seizure, keeping a record of what you see. Is a particular arm twitching? Are they blinking their eyes? Are they twitching in one side of the arm or the other? Those things tell the neurologist a lot about what's actually going on. Helps to identify seizure triggers and patterns. And yeah, there are also various apps that can be used for keeping track of these things that then can easily share it with the neurologist. At the bottom there it says we can email you a seizure observation record, we in this case being the Epilepsy Foundation. If you're a caregiver for someone and you'd like to have just some of the basic stuff for that, we can get that to you very easily. The next page is the seizure action plan, which is a plan that's developed with the neurologist and the person and caregivers working together to provide basic information about the nature of the seizures, the first aid in particular to them, and the emergency response for various circumstances. And we distribute this to relevant people, organizations, schools, when a diagnosis is made. Yeah, and again, that if you want to contact the Epilepsy Foundation, we can get that to you. The next page, the hospital action plan, is pretty straightforward, really just the importance of loved ones being proactive when it comes to these things and making sure to share with the doctors as much as we can. So as to get as much data and as effective treatment as possible. Another case where the use of the smartphone medical ID can make sure you're always getting all the information necessary to the doctors. And yeah, the last of the hospital action plan, you want to include the seizure diagnosis, description of them, the list of the name and diagnosis of all the medications and rescue medications, information about VNS, RNS, DBS, all of the relevant medical information, allergies, surgeries, procedures, emergency contact info for family members and advocates, the names of neurologists and such things. You know, for those of us on the journey, so often these things occur in very, very annoying times and places, and so having these things in place, you know, allows the information to be communicated even when you might not be completely able to communicate it. Yeah, and that last page is, again, pretty much just we can get the hospital action plan stuff to you to share in ways possible. Finally, we are here to help. On the next slide, just the Epilepsy Foundation itself. If you know somebody who's dealing with this kind of stuff, whether it's a family member or a friend, sharing and encouraging people to get involved. There is, because of the stigmas that come with epilepsy that are age-old, and there are huge amounts of isolation that occurs. I can speak from that on my own journey, an inclination to kind of not want to find out how bad it is. But the Epilepsy Foundation does an amazing job of sharing resources and you know, helping you find doctors and therapists and people who can help with the complex journey that it is. The next slide, November is National Epilepsy Awareness Month, just some other activities that are done with the Epilepsy Foundation. And that's about it. Does anybody have any more questions?
Where's the epilepsy walk?
The Epilepsy Walk is basically across the street at Rose Valley Park. Rose Tree Media, that's what I mean. Right, yes, that's where every year in June, the Epilepsy Foundation, the Philadelphia branch of it, does a walk to end epilepsy over there. Yes, sir.
This is sort of a personalized question, but for me and Cadman, since we're kids, as soon as something happens with someone with a seizure, and we know this, what should we do? Because there are adults around and they might not take us seriously.
So the question from my kids, who know a lot more about epilepsy than the average kids, is what should we be doing if a person has an epileptic event, you know, at school or in some other setting? I mean, in an emergency setting, you guys know a lot more than most of them are. Don't hesitate, especially you're the outgoing one. Don't hesitate to tell people what you know about it, because you know, I guarantee you know more about it than most 12-year-olds. And yes, even most of the adults do not know as much as you do.
Just like something comes up, like it's something.
Good question. And now it's your job. Anything else?
Yeah. Oh, no, sorry, hold on. One more.
How do we get the certification? Which is easy, but then the other one.
Yes.
Someone is having
If someone is having a seizure and has one of the implants, are there circumstances where a bystander should activate it, or how would you know? Would they have some indications, or is that not something you should look for?
So that is one that, again, is sort of a blurry line. If the person is wearing the wristband of a VNS, it is relatively easy to swipe that across this region where that gets used. If it's a person that you know, like those of you here at the UU Church, my RNS is something that the nature of my seizures is that I'm conscious when I need to be using it, basically, so I use it myself. But if you see me taking this out and flashing it on my head, hang out and make sure I'm okay. The other question was the certification. So for the people online, put up my email address. You can contact me via my email address, and I will make sure to get your names filed. And for those of you here, you can talk to me afterward. So the certification is valid for 2 years. If you're not doing any jobs where you need the certification, it's not essential to get the official certification, but I am happy to do it for any and all of you that would like me to officially file your name as being first aid certified for seizures. Anything else? Yeah.
Thank you. Thank you for all the information, but also your personal sharing.
It
has cascading effects of our awareness now, so thank you, Jeff.
I appreciate it. It is a calling on a journey that I didn't really go wishing for, but sharing about it. You know, I'm far from an introvert, so sharing isn't hard. But acceptance of the journey has taken a while. But that's true for all of us on our various journeys. All right, we'll call that a day.